Thank you. And welcome everyone to this evening's medical retina teaching with Mr. Mohammed. Over to you.
Thanks. So CSR is one of my favorite subjects. I'm not quite sure why, but I think we run one of the only specialist CSR. I run one of the only specialist CSR chronic CSR clinics where we do actually more PDTs than anyone else in the country. So we keep getting told by the manufacturer. So if there's any questions, by all means, just interrupt whenever. So CSR and the pachychoroid spectrum, this has all sort of evolved over the last decade or so, the whole terminology and lexicon around this subject, and as our understanding of deeper imaging on the OCT of the choroid. So it is central serous chorioretinopathy, not central serous retinopathy, because all the pathology happens in the choroid and the retinal complications are just secondary manifestations. So that image at the top is a beautiful autofluorescence image showing all these gravitational tracks and retinal pigment epithelial changes, which are a really defining characteristic of chronic disease or chronic persisting disease. Oh, I think I've got a problem with my computer here now. Okay, so it's a common condition. It's the fourth commonest condition we see after AMD, diabetes, and vein occlusions. But of course, it's never conventionally thought of that because in the majority of patients, it is settled spontaneously. And I think everyone's aware of that male to female difference, where it's somewhere between 5-6 times more common in men than women. So if you look at these prevalences and incidences, it's something like 10 to 50 cases. So USA sort of mixed population, Japan 50 cases per 100,000 of the population, and in women somewhere between 2 and 15. So it tells us there's a sex difference, but there's also a racial difference. And of course, if you see that, you always suspect some sort of underlying genetic basis. So this Manhattan plot of genes has a number of risk genes which predispose people. Of course, you know, every structure is defined by genetic differentiation. So the choroid and its thickness and the scleral thickness, which is probably interrelated in CSR, undoubtedly has some sort of genetic basis to it. So, you know, the textbook teaching is always that it's primarily a disease of presbyopic men. And of course, presbyopia happens earlier in hyperopic or long-sighted patients. So the sort of late 30s, 40s, 50s is the key age range where people present. We've seen people in their 20s, we've seen people in their 80s, so it does vary. By definition, it's a focal detachment of the neurosensory retina, so that's fluid in the subretinal space, which is seen here. So we can see the pigment epithelium is flat on the OCT, and plus or minus areas of detachment of the pigment epithelium. So almost invariably, we see tiny little pigment epithelial detachments, and sometimes quite big ones as well. And just to add to that, that's the sort of basic definition. To add to that, it's over areas of thickened or thickened and dysfunctional choroid. So we know it's central serous chorioretinopathy, and the pathology is in the choroid, and it happens in one or both eyes. And more often than not, we'll see irregularities in the pigment epithelium in the fellow eye of an affected eye. So what we really want to do with this talk is just go through these sort of new and emerging definitions. I'm sure most of you will be familiar with the pachychoroid spectrum now. Sorry, I'm going to take a quick slurp of my tea. And then recognize that complex and chronic disease is an issue and what its complications are. So Bhavina just said a minute ago, you know, when do you refer in? Well, the minute you suspect that CSR isn't settling of its own accord, which is what 85% of cases do. And then it's really important, and this is really poorly understood amongst ophthalmologists as well, that is that timely intervention is really necessary to reduce poor visual outcomes. And ultimately, we're not tolerant of fluid. We really want to preserve the outer retina, that's the photoreceptors, and really aim for a full resolution of subretinal fluid. If that doesn't happen, the retina withers away. So here's a case of a chronic CSR. So if we just go back to the previous one, acute CSR often has this very steeply domed appearance, whereas chronic CSR tends to have a much thinner sliver of fluid. So the things we can see on this particular OCT scan is the choroid is really quite thickened, and we'll talk about what the definitions of a thickened choroid are. Sorry, is there a question there?
No, I think someone's just off mute, so I'm just going
Oh,
to put
okay.
them on mute. Thanks.
And so thin sliver of fluid. And then if you look very carefully, you see this little debris on the inner aspect, these little stalactites or deposits, often hanging off the photoreceptor outer segments. And that's really shed photoreceptor discs. And it's thought to be a feature which only really develops after 4 months of persistence and chronicity. Other changes on this scan are, if you look at the outer nuclear layer, the dark band here really becomes quite thinned out on the foveal thickness. So we know there's multiple changes on this just very simple scan. It's not just fluid. We've got evidence of chronicity. The fovea is thinned out because the foveal central thickness is usually somewhere between 250 and 280 microns, and that's down to 75, 80 microns or so. We've got this little caliper here, so it tells us certainly less than 100 microns. So there's foveal atrophy there as a result of that chronic separation of the retina from its nutritional supply, which is the pigment epithelium and choroid. So pachychoroid is the key thing. So we'll talk about what the definition of that is. And then this concept of intervortex anastomosis, which is something we see on an angiogram. It's important because if we're struggling with a diagnosis, which we don't do very often, we'll do an angiogram. And anyone who gets chronic disease will always do an angiogram because treatment is based on angiographic results. So here we've got a normal OCT, which is our reference scan. And here's a patient with a terrible chronic CSR. So there's pachy-drusen here, pigment epithelial detachment, and then there's whopping huge choroid. So if you see the normal choroidal thickness, which is usually less than 350 microns, and you can see this choroid here measured from the pigment epithelium to the sclerochoroidal interface, where you just see where the sclera is. You can see it's not just thickened, but those changes happen in Haller's layer. So remember, the choroid has got 3 layers. There's chorocapillaris, which is the capillary side of things with this fenestrated capillaries. The Sattler's layer, which are the medium ball vessels, and the large ball vessels are Haller's layer. So there's a whole bunch of conditions on that pachychoroid spectrum which we recognize now. Let's say this terminology really didn't exist a decade ago. So in terms of definition, it's focal or diffuse thickening primarily measured under the subfoveal space. So again, everything gets complicated because there is variation just by age and refractive error. So, myopes tend to have a thinner choroid. The thing to note is CSR is really, really very highly unlikely in myopic patients. We did say presbyopic, hyperopic males is the standard patient, but, I treat 150 plus chronic CSR patients, and I can count on one hand the number of myopes I've had in the last 5 years. Very, very few. So there's no absolute accepted definition, but anyone who's got a choroidal thickness more than 400 micrometers, so from there to there, is a very suspect choroid. But we have this range of changes. So you can have an uncomplicated pachychoroid where someone just has a thick choroid, but no secondary consequence, so no CSR or no pigment epitheliopathy. And then you can have a pachychoroid phenotype as well, where you have these very, very dilated vessels. So just going back, comparing to the last scan, normal choroidal vessels, the large ball vessels shouldn't be huge. There should be that sort of size. So the large ball vessels are here. The medium ball vessels, Sattler's here, and chorocapillaris should look like that. But if you look at this picture here, there's actually huge voids in the outer choroid, and the medium ball vessels have really disappeared. And you often see these granular changes around vessels as well, suggesting, or it has been suggested, that there's some sort of inflammatory process going on, but not an inflammatory process where we'd give steroids for, because that classically aggravates the situation. So again, it's all evolving terminology. Primarily, it's identifying very large bore Haller's layer vessels and thinning of the inner choroid. So chorocapillaris thins out. So you can just imagine that actually the inner choroid, the chorocapillaris, is ischemic. You've got shunting out in the outer choroid. So blood is just bypassing supplying the chorocapillaris and RP. So essentially, it's an ischemic photoreceptor disease. It has been said that it's still incompletely defined and it's quite a nebulous description. But in actual fact, in most patients, we'll say the choroid is abnormal in these cases. Um, so what underlies that thickening is abnormal vessels. So we call them pachyvessels. And this seems to relate to some sort of choroidal venous congestion. So remember, the choroidal veins drain out through the vortex ampulla. So you've got somewhere between 3 and 8 vortices, but usually there's 1 or 2 in every quadrant. And then the unusual thing is each quadrant has its own drainage, and you're not really supposed to. So the superior hemisphere drains into the cavernous sinus. The inferior hemisphere drains into the inferior pterygoid plexus. So it is an unusual organ because you don't have differential blood drainage in really any other organ system in the body except the eye. So this quadrant really should just be drained by vortices here. So in this case, what we see is large bore blood vessels crossing the horizontal and vertical meridian, which really shouldn't happen. So we just know they're immediately suspect and most likely to be pathological if the blood vessels are dilated. And then the other thing we say is patients get intervortex anastomosis, which I'll come to in a moment. So we get this attenuation of the inner choroid. Chorocapillaris thins out, and it's really very dilated uh, outer outer choroidal vessels. And then we've known that it's choroidal dysfunction for quite a long time, since ICG angiography came into being in the late 80s. So we've known that in the mid to late phase of ICG, you get this choroidal ischemia and dysfunction. So poor filling initially on the ICG, and then late leakage on the ICG, which has a very characteristic lobular pattern on the ICG, and it seems to represent some sort of ischemic damage at the chorocapillaris. It's supposed to be an OCT talk, so I won't dwell too much. And we said that these blood vessels, because they're very congested, say in one quadrant, then to relieve that abnormally high pressure, they develop anastomoses across the normal drainage patterns. So we see many, many blood vessels crossing across the horizontal and vertical meridia. Now, of course, people do have these vessels crossing over, but they don't tend to be so large and so dilated. And most physiological vessels taper, so they're narrowest at the most peripheral and distal part, and widest at the point of exit. So in these cases, say you can see here, obviously vessels should taper, so they should be very thin here and then get wider and wider as they drain out, but they're just unusually large, which tells us something abnormal is going on. And the most recent theories seem to suggest that there's some abnormality in the sclera which causes this. So another term has been applied, which is venous outflow choroidopathies. And so the primary pathology seems to be not just choroidal dysfunction, but it's the way these blood vessels drain out of the sclera. And of course, hyperopic eyes tend to have thicker scleras, and then it ends up with an overlap with patients who have got nanophthalmic eyes and end up having things like uveal effusion syndrome. So it's an interesting field because all these theories are sort of evolving year by year. So one sort of there was a good paper here. Oh, I can't. I've got something in the way on my screen. This paper here, which is interesting, recently published in Eye within the last year, from Jemmy Chung, who does a lot of research on CSR, said that it's things like short axial length, hyperopia, asymmetric vortex vein drainage are the anatomical predisposing factors. There's often some sort of inciting event which causes further blood vessel dilatation, whether that's steroid intake. There's a few theories as to how steroids affect the choroidal vasculature. Um, Stress, and that's the sort of stress hormones, which is steroid, and there's some other factors identified as well. This causes that overloading in Haller's layer, and then these are the compensatory mechanisms, and there's this vicious cycle of choriocapillaris impairment, which then causes outer retinal damage at the pigment epithelium, so there's pump dysfunction. So remember, it's not just fluid uh, pumping out in the wrong direction. Remember, the RP pumps fluid from the vitreous towards, or from the retina into the choroid, and then you've got this reverse pumping, and then that it ends up causing, if you're not nourishing the photoreceptors, then outer retinal damage. So which is what we end up seeing in patients with really photoreceptor atrophy and foveal thinning, and established geographic atrophy in very advanced cases too. So the sort of the emerging spectrum of changes, the classic condition is central serous chorioretinopathy, but a whole bunch of other pachychoroid diseases are identified. So when we always looked traditionally at the fellow eye of a patient with CSR, we'd see pigmentary irregularities. We'd say, oh, you must have had CSR in that other eye before. But we now sort of label that as pachychoroid pigment epitheliopathy, and it's probably that ischemic damage. So you just see little spots of focal hyperpigmentation irregularities in the RP, in the fellow eye of eyes. And that's seen in probably 90% plus of cases. There's pachychoroid neovasculopathy, which is macular neovascularization as a result of chronic persisting central serous chorioretinopathy. So many diseases will end up with secondary neovascularization, and we've already said this is an ischemic disease. If there's ischemia, VEGF is released. VEGF is a classically pro-angiogenic disease causing new vessel growth. And then PCV is also seen. So that, of course, is just a variant of neovascularization. Something in certain patients, probably high blood pressure, tends to cause aneurysmal dilatation. So again, we know PCV can be in AMD patients with a thin choroid, but it can also be in patients with a thick choroid as well. And then there's another entity called the peripapillary pachychoroid syndrome, where most of the changes happen between such as in this case, all the changes around the optic disc. And that's a particular nightmare to treat because these patients end up getting secondary cystoid degeneration of the retina, affecting the papillomacular bundle. And the most recent incarnation, which was again just described within the last year, is pachyvitelliform maculopathy. It's quite rare, but again, you get a vitelliform type change as part of that CSR or pachychoroid disease spectrum. And there's a few other things, pachydrusen, which are drusen, not age-related drusen. These are in younger individuals, which are patchy, asymmetric, as part of that thickened choroid. And that it seems to be a knock-on effect on the pigment epithelium. And then peripheral exudative hemorrhagic chorioretinopathy or peripheral eccentric disciform seems to be on that spectrum too. And then another entity, focal choroidal excavation. So I'll show you a few examples of these. So CSR, we've already shown a couple of images. I've already shown these pictures. So acute CSR tends to have that steep dome and a thickened choroid. And we can start seeing here already that you can see that it's Haller's layers vessels, which are particularly abnormal here. And there's sort of irregularity in the choroidal profile as well. So typically it's thickened just under the foveal center. And this patient has got a much thinner sliver of fluid, which is much more consistent with chronic CSR because the retina is thinned out a little bit. You can see what the outer nuclear layer here really becomes very attenuated here, almost sort of non-existent. And you can see on this picture that there's a pigment epitheliopathy. This mottled appearance of the pigment epithelium tells us that there's widespread damage of the pigment epithelium, which is very essential for the whole metabolism of the photoreceptors. So in terms of pachychoroid pigment epitheliopathy, I mean, typically in medical retina style, these things get split to the nth degree. So there's different types of pachychoroid pigment epitheliopathy, but classically we say it's little RPE changes or pachydrusen type changes. So these are little drusen, these are some RPE changes. On the infrared reflectance, pigment looks, it's a different patient. Pigment looks white, so these are widespread RPE changes in the patient. This is post-PDT, so the choroid is thinned out, but there's abnormally dilated outer choroidal vessels. Pachychoroid neovasculopathy is always suspected in any chronic CSR patient who's got this shallow pigment epithelial detachment, and it's more common than we think. Something like 40% of patients with chronic CSR end up getting secondary neovascularization, which is a nightmare treat because you never know whether the fluid is coming from CSR or whether it's coming from the neovascularization. I'll talk a little bit more about that in a minute. And the only test that really picks up that neovascularization is an OCTA. Conventionally, fluorescein angiography is our gold standard test for neovascularization. But because you have this underlying pigment epithelial change, fluoresceins just don't pick up the change. And of course, in CSR, you tend to get a brisk leak. And similarly with ICG, there's a choroidal leak. So it's very difficult to pick up neovascularization. So it's only with the advent of OCTA we really recognize pachychoroid neovasculopathy as an entity. So again, PCV, we see, so on this patient in cross-section just below the foveal center, we can see the choroid is quite thickened. What we understand by this pachychoroid phenotype is very enlarged vessels. And then we always suspect PCV in someone who's got a bilobed or multilobed pigment epithelial detachment. You can just see within here, there's a little structure within, so it's not completely homogeneous what's filling that. You can see a little circular elements within, and then this shallow irregularity just slightly higher up undoubtedly is the branching vascular network. So of course, polyps tend to grow at the edges of a neovascular complex. The branching vascular network is the neovascularization in the middle. And anyone who we see these little domed peaked elevations, particularly with these circular structures, we say have got polyps. And the advantage of picking that up is like it tends to be quite volatile. So these things bleed and can bleed quite heavily. So the best test for picking up PCV is video ICG because these things often pulsate and that tells us they're particularly unstable. So they glow up and light up beautifully. And then this little complex, you can see there's little blood vessels growing out of that as well. So the peripapillary pachychoroid syndrome is where the choroid is more thickened between the disc, the optic disc is here, and the foveal center. So you can see this bit of choroid is far more thickened than this side. You've got these same pachy vessels, this sort of granular change, and you often get this cystoid degeneration. So it's often mistaken for CNV because there's intraretinal fluid. But it is a very, very latent chronic feature when we see cystoid degeneration, almost always between the fovea and the disc, and almost always with these very dilated vessels, which are greater in depth between the foveal center and the disc. And when we do an ICG, we'll see often a network of abnormal blood vessels going around the disc. So this is a patient with peripapillary pachychoroid syndrome. So on the autofluorescence, all the changes are between the fovea and the disc. We can see the intervortex anastomoses seem to wrap around the disc. And again, very thick choroid, cystoid degeneration. And on the infrared reflectance, lots of RPE changes, again, mainly concentrated on the nasal aspect of the macula. Pachyvitelliform maculopathy is where you get a very sort of typically vitelliform looking lesion. We always have to be careful in these because sometimes with very brisk leaks, you get fibrin deposition in the subretinal space. So you don't see clear fluid, but fibrin doesn't autofluoresce, but these pachyvitelliform maculopathies do autofluoresce, and that seems to be the difference between the two. But that's sort of exceedingly rare. There's only a handful of cases reported in the in the medical literature. And then focal choroidal excavations, again, has always, I'll put it in brackets because for the last 10 years or so, it's always been put down as part of the pachychoroid spectrum. But there's been some reports more recently saying, well, we do see it in a lot of other conditions as well. So whether it's truly related to CSR, but we do see it in a disproportionate number of cases. So again, thickened choroid here, anomalous choroidal vessels, and how there's a dip of the inner choroid. And we've said this is a condition of inner choroidal ischemia. So it does seem to make sense that it's part of the spectrum. And in this case, it's a conforming focal excavation because it drops into that defect. Sometimes we see non-conforming where it just drapes straight across and you get a void under the retina, which isn't quite subretinal fluid. It's not elevated the retina, but just seems to be a void and cavitary defect. There's loads of other conditions which cause a thickened choroid, which aren't on the pachychoroid spectrum. And then there's other conditions which cause choroidal vascular permeability, but that is up to us in clinic to then decide, is it really a masquerade syndrome or is it just true chronic CSR? But most of these things are quite unusual and quite rare. So the terminology used in clinic as to whether something's acute or chronic, and this does tie into when you start referring patients. By definition, or there's never any sort of fully accepted definition, but the proposed definitions say an acute episode should appear typically steeply domed and fully resolve without a diffuse retinal pigment epitheliopathy, which is a hallmark feature of chronic disease. Inactive CSR is where you've had an episode which has subsided and with no residual serous retinal detachment. Recurrent is where there's an episode which settles and then recurs again because the underlying choroidal dysfunction still goes on. So they're the sort of terms that are used. And again, there's no sort of accepted time point, but we know people start doing badly when there's persisting fluid beyond 4 months. So when you see these elongated tips, we can say almost certainly this has persisted for at least 3 months, if not longer. And that will be the time to start. And we see this in clinical practice. A lot of colleagues, I do a tertiary referral clinic for chronic CSR for a big wide area of the south of England. And people sit on these cases with the hope that it goes away. Certainly in Hong Kong and Singapore, where they have Oriental patients much more predisposed to getting chronic CSR, as are South Indian patients and Sri Lankan patients. So these patients tend to have a worse outcome. So for those individuals, we prefer Chinese and South Asian patients, South Indian patients, we prefer seeing early just because the outcome tends to be genetically slightly worse. And then chronic CSR, again, there's no accepted terminology, but I think most people will say if there's fluid which has persisted more than 6 months, then that's chronic. And then the defining, so that's a temporal definition. And then the anatomical definition is this diffuse pigment epitheliopathy, this mottling, which is really picked up on the infrared reflectance image or the autofluorescence image. Oh, and what I was saying is that the Hong Kong and Singapore groups now more and more seem to recommend that you treat 3 months in those patients to get the best visual outcomes in the long term. So we've already mentioned there's no sort of standard accepted definition, but most people accept that persistence more than 6 months is problematic. On a fluorescein, we often get these atrophic cracks, and fluorescein tells us about the health of the pigment epithelium. It masks the choroidal vasculature, so you can see a wide, deep mottling here, and that again is a hallmark feature. And then the pigment epithelium here, you can see transmission lines telling us that the pigment epithelium is compromised. Not only that, but obviously the outer retinal structure, we've got foveal atrophy here, the outer nuclear layer is gone. So even if you treat these patients and they end up with that result, they'll never really regain full visual function because the retina has been permanently and irreversibly compromised. And it's still really not known whether acute disease goes into chronic or whether acute and chronic are two separate entities. I think they probably are two separate entities. You can get acute persisting CSR, where you don't have this pigment epitheliopathy change. But the true chronic patients do end up having this widespread irregularity at the level of the pigment epithelium. So the problem with these, and the reason why you need to refer these patients in, so again, because of all the inevitable delays with referral and then vetting and then appointments being generated, is I would say if the patient's not fully resolved by 3 or 4 months, and they really should get sent in. If the vision's quite poor, it may be worth sending patients into some sort of rapid access clinic as well. And the reason is that these patients end up with poor anatomical and functional outcomes. So whilst acute simple CSR settles in 85% of cases, actually lots of studies have shown actually there's moderate visual loss, which is a doubling of the visual angle, some even quite profound loss. We do see patients occasionally at 660, 360 level coming in with CSR, and there's not really a great deal we can do. And other things like visual function questionnaires all significantly decline. These patients have visual dysfunction primarily, so apart from the micropsia and contrast loss and color desaturation, there's other aspects of binocularity which are lost. So it's not just the acuity where interesting. The acuity is often reasonably well preserved. So what we see with chronicity is outer retinal atrophy. So I've already mentioned this, that the fovea thins out. So the central foveal thickness should be somewhere around 250 microns. This patient is down to 75 microns. Of course, we said the retina is central nerve tissue. It doesn't really have a power of regeneration. So once it gets down to this level, we do always give a guided outlook in terms of what they can expect with treatment. And then the pigment epitheliopathy, the best way of looking at it is with autofluorescence. So the pigment epitheliopathy looks like this. So stressed RP is white, dying RP is very mottled, dead RP is black. And then you can get similar correlates on the infrared image, but we certainly do multimodal imaging and always get a autofluorescence on patients with chronic CSR. And then I've already mentioned macular neovascularization is a thing, and it seems to be somewhere around the 40-50% mark of patients who will end up getting neovascularization. So anyone who's got a double layer sign, so we can see Brooks membrane there, and a shallow, irregular elevation of the RP, little tiny pockets of fluid, little transmission defects overlying a thickened, not hugely thickened, but certainly very anomalous Haller's layer vessels here, which I think you can all see. And then this mottling here. So macular neovascularization is a problem because new vessel growth can bleed and then scar, etc. And I've already mentioned, it really is the OCTA which shows these complexes like you can't see on anything else. So this is the same patient. This looks really quite inert and inactive, but it's a really mature frond of new vessels which is there. So this is the thing that in CSR, the neovascularization doesn't quite behave like AMD neovascularization, which grows rapidly. It's thought to be some sort of slow reparative mechanism. And classically, anti-VEGF agents, or the VEGF assays aren't high, so anti-VEGF agents don't work brilliantly. More often than not, we do combination therapy where we will do 3 anti-VEGF injections first and then often do PDT thereafter. And it seems to be that combination is the most effective in stabilizing these patients. Serious PEDs are another thing. And we wrote up a series, or the first series ever describing that PDT works just for isolated serious PEDs as well. So these could be problematic. Again, people mistakenly, or amongst ophthalmologists, mistakenly say if there's no subretinal fluid, it's not active. The natural history of an isolated PED is either it will undergo atrophic collapse, or it can grow, or it can tear, or it can get secondarily vascularized. They don't do well in the long term. So we end up doing, if there's subfoveal or symptomatic isolated PEDs, we do PDT on these, and it seems to, again, work pretty well, about 80-85% of cases. There has been a sort of more recent proposal moving away from this acute and chronic definition, and that's really to try and encourage the ophthalmic or the ophthalmologist to think differently about CSR. I think it's fairly clear cut. Chronic diseases, if anyone you suspect it, anyone who's had persisting fluid for more than 4 months or so, you start the ball rolling for referring these patients in. And this new proposed classification says to make that diagnosis, you have to have both of these major diagnostic criteria, which is evidence of subretinal fluid, subretinal serous retinal detachment, and RPE alteration. So it actually brings into the definition an autofluorescence or infrared imaging. You have RPE irregularities, and then any one of these minor diagnostic criteria, which is ICG mid-phase leak or more than one leaking spot on a fluorescein angiogram, or a subfoveal choroidal thickness more than 400 micrometers. So this is attempted to really define and drill down onto what CSR. And these are all the masquerade syndromes. There's lots of things that can look like CSR. Dome-shaped maculopathy and staphyloма-associated fluid tend to be in myopes, and we've said myopes don't tend to get CSR, particularly high myopes. It's almost unheard of. Things like uveal effusion, secondary vitelliform things can end up disc maculopathies that have superficial resemblances, but when you look very carefully, you can really differentiate the two quite easily. And then we've said features of chronicity, just to reiterate that, is outer nuclear layer loss, RPE atrophy, the ellipsoid zone and ELM disruption. That's all part of atrophic change. And RPE attenuation, where the RPE dies off, which we've said right at the beginning, is just a manifestation of that ischemia. So that's what these conditions look like. So the major criteria we said are serous retinal detachment and RPE alteration. So serous detachment, we know fluid is black under the retina. RPE alteration on an autofluorescence or RPE alteration on an infrared image. And then the minor diagnostic criteria. So you have to have both of those to make that diagnosis according to this new classification. And then the minor criteria on ICG, you see mid-phase leak, has a very pathognomonic appearance on ICG. And the mid-phase of an ICG is 10 minutes plus. Fluorescein, you get this ink blot leakage, which is the most common pattern, and other things like smokestack and what have you. But this is the thing we see most. And we often think about doing just focal laser therapy if we see that. And then the choroidal thickness. But more importantly than the absolute measure, it's the fact that the choroidal outer vessels are anomalous. And then using those factors, they say not acute or chronic, but simple or complex. And then it's either primary if it's a first episode, recurrent if it's been noted before, and resolved if it's completely absent. Persisting, so their definition of persistence was more than 6 months, but we do get better outcomes by intervening earlier. And then the late complications are, as we've already said, outer retinal atrophy and choroidal neovascularization, which are the things we try and avoid getting into the territory of. So for a few years now, people have sort of tried to define algorithms as to when you treat. So acute CSR, you can see here that you think about treating patients if there's fluid beyond 4 months. So if highly symptomatic, recurrence episode, bilateral, particularly if there's a bad outcome in the fellow eye, or if the patient's occupation has a high visual demand or they notice it, then we certainly do think about doing early treatment. Generally, I tend to wait at least 3 months because quite a large proportion of patients do just spontaneously settle and then don't reactivate. But the textbooks do say the average patient has somewhere between 3 and 5 episodes in their lifetime in either eye. And then this proposed algorithm for treatment for chronic disease said if there's fluid longer than 4 to 6 months. So again, there's consistency in the world literature that if the fluid persists longer than 4 to 6 months, then do something about it to avoid these late complications. So we'll just rattle quickly through these things. Most spontaneously settle, as we said, the conventional wisdom says 85%. If patients are on exogenous steroids, whether that's drops or creams or tablets, of course, if it's safe to stop, we would encourage them to do so, or certainly reduce the dose. That implication with, the interaction with exogenous steroids is proven statistically. There's very few things which are, in terms of CSR. It's primarily um, tablets or exogenous steroid prescribed medications, but many of our patients have got asthma or various things, so it's just generally not possible to take things to reduce steroids in all cases. But the literature seems to suggest that almost 90%, if it's steroid related, it isn't always, will just settle if you stop the steroid medication. And then a guide for, again, referring in if they're very symptomatic, if it's recurrent, certainly if they've had a bad outcome in the fellow eye, or if the patient prefers to have something done. Because there's that thing with the personality type in CSR, they're always quite high demand patients as well. And we know the literature says it, and sometimes you take that with a pinch of salt, but it's certainly something we see. These patients are often pacing up and down the clinic and really quite impatient with various aspects of their life. Um, you may and may not be familiar with mineralocorticoid, so that's eplerenone. Spironolactone is not used, but good big trials. We were part of the Vici study, and they showed that actually the drugs just don't work. So there's just no role for them. But unfortunately, disappointingly, we still see patients referred into our tertiary clinic who have been on these agents for like a year or so, but the literature says they don't work. I think a micropulse. There's a couple of centres in London who offer micropulse, but there's lots of criticisms of firstly, there's no such thing as standard micropulse. It depends on which company makes the laser. So the studies and literature are really quite inconsistent. And of course, the natural history is a lot of patients spontaneously resolve anyway. So there's not really been any brilliant clinical trials proving the efficacy. The best trial was probably the PLACE study, where half-dose PDT was compared with micropulse or this non-damaging laser treatment. And it was something like 3 times the number of patients were successfully treated with PDT rather than micropulse. So again, I don't think micropulse has any role. It's sold as a non-damaging treatment, but we know the autofluorescence changes in these patients. And what you really want to preserve is the RPE, which is a natural pump. PDT addresses the choroid, which is where the pathology is. Micropulse treats the RPE, so it doesn't really make any or any sense to me as to why you do micropulse when it doesn't affect the long-term outcomes. You do nothing for future recurrences, whereas PDT is disease modifying. It cuts down the rate of recurrence. Focal laser we do just to hasten the resolution of patients. It works very, very well. But if you've got a subfoveal leak, we tend to avoid lasering under the retina. So it does work. And then we've had lots of problems with verteporfin, the drug used for PDT, and its supply over the last 5 years. So we've probably done a bit more focal laser than usual, but it certainly works very well with a high success rate. So this is an example, someone who had subretinal fluid for 9 months. The point of leakage was up here somewhere. So often the fluid, you can see big sort of fluid all pulled down by gravity, doesn't correlate. This is an ICG, so you can see there's very odd filling. So this is what we define as choroidal ischemia on an ICG, very large abnormal choroidal vessels on an ICG, and on a fluorescein we get leakage. So that's focal leak. All that fluid came from one point. So we zapped it with a laser. So that's the fluid before, after focal laser, and the laser is done up there. The fluid just disappears and melts away, and we do a follow-up scan 6 weeks after the treatment, and a high proportion of patients, sort of 80–90%, will settle if they're amenable to that. Not everyone is. If you've got multi-point leak, or if there's a diffuse pattern of leakage, which we typically see with chronic CSR, then focal laser doesn't really have a role. So this is a patient who is enrolled on the Vici study, had eplerenone for a year, very, very thin choroid. You can see some pigment epitheliopathy here as well. Seems to be a focal leakage point, quite close in, But when we measured it, we felt it was far enough, or I felt it was far enough out that we could safely laser. So there's a leaking point there, just a couple of very gentle spots of laser. That's before and that's after. So it works really quickly, very effectively. And this is another patient with very chronic, widespread disease, multiple leaking points. There's a little bit of fibrin with that, so it's not black, the fluid. It's a bit sort of hazy in its appearance, and that tells us the leak is often brisk. The autofluorescence tells us a huge puddle of fluid, pretty much encompassing the entire macula, and the fluorescein angiogram told us there were 1, 2, 3, 4, if not 5 leakage points. So all those, so within that there were 5 leakage points, because that's a separate point, that's a separate point, that's a separate point, that's a separate point, that's a separate point. So we zapped all those. That was before focal laser. So that's quick, easy. It takes less than 5 minutes to do. Obviously, we need to do the angiogram beforehand, and it works very well, but it doesn't do anything to the underlying choroidal problem. The choroid still stays thick, and these patients still have risk of recurrence because the underlying pathology is still there. So there are risks. We don't do laser too close in, but it tends to be pretty safe. Modern lasers are not really as damaging as old-fashioned argon laser was. There is the CNV rates, but again, in the old literature, but we don't know whether the CNV is just part of the complex, which we do recognize that it is. PDT is certainly now the standard of care and has been. I mean, we've been using I've been using PDT for 20 years now. Januzzi, who did a lot of research in the early 90s, in a editorial wrote that it's a standard of care, and 60-70% of patients of specialists who have a particular interest will offer this as their first line treatment. There have been issues, there's still ongoing issues with Visudyne, the drug that we use. It used to be made by a company called Novartis, who weren't making a profit because the drug was originally developed for choroidal neovascularization, but it was just found to have a secondary benefit. In actual fact, it works far better for CSR than it ever worked for CNV. But then they flogged the drug to a different manufacturing company, and they've just had problem after problem. So there's been a very sketchy supply of the drug. So we ended up having a backlog of about 150 patients, but we managed to treat them all in the last 6 months. So we have got a supply. So it should be standard of care, and I've been giving talks on CSR for at least a decade at college meetings and what have you, but we still see over and over again that patients are sat on because it fluctuates and waxes and wanes so much. There's often this misconception that, oh, the fluid is dry, so it must have cured by now, but it does seem to just recur. So in patients who have got persisting fluid, even if they're dry, we still end up PDTing patients. And the difficulty is the company never did a formal clinical trial because they're never going to turn a profit. And that's a very cynical viewpoint, but the use is relatively low as opposed to the thousands of patients who would benefit from, the use of the drug for choroidal neovascularization. And it's a photodynamic treatment, so it's a photochemical reaction. It's the action of light, a laser, on a photosensitizing drug. So when the inactive drug is activated, it releases free radicals and various other chemical reaction happens in the dysfunctional choroid, and then the choroid definitely does shrink down. So we can guess on just a combination of the ICG, the vision, and the OCT as to who's likely to respond and who's not likely to respond. The best patients are ones who haven't been sat on too long, so they're treated within 6 to 9 months of the onset. The ones who've got brisk leak and still a preserved RP. The ones who do badly are eventually these changes burn out. And if the retina and the RPE particularly is very compromised, then these patients end up with pump failure. So there is definitely a window of opportunity, which does definitely mean that if after 4 months you're monitoring them in practice, if it hasn't resolved, please do send them in to be seen sort of urgently. And then the OCT-A and OCT all shows that it does address, so the blood flow in choroid capillaris seems to become restored, and the choroidal volume and choroidal thickness reduces, and it seems to confer this protective benefits in the long term. So when we last audited, which was quite a long time ago, 85% of our patients settled with just one cycle of PDT. And then when we do 2 cycles of PDT, about 91% of patients responded. But the patients who fail are the ones who primarily were, as I just said a minute ago, who had a long duration. So, we optimally treat our St. Thomas's patients. Will list and do PDT. A lot of our patients are tertiary referral patients who have been sat on elsewhere in different clinics, which is why things just need to be acted on quickly. So I'll show you a couple of examples, and then we'll stop after that and can look at the image that we've been sent. So this is a CSR patient. So in the new terminology, simple, meaning there's not widespread pigment epitheliopathy. Primary, meaning it's the first episode. Persisting, meaning it's been there longer than 4 months, and plus disease, meaning there's some secondary consequence, which is thinning of the outer nuclear layer. And the fellow eye has got pigment epithelial changes. So we often see these in fellow eyes. We often see the choroid is thickened in the other eye as well, which hasn't got CSR, but dilated vessels. On the fluorescein, quite localized change, so not widespread pigment epitheliopathy, but very dilated vessels coming in very close to the middle. The choroidal vessels should look like this in the top half. They're not particularly dilated, but you've got vessels crossing over. And then there's leakage on the fluorescein, and on the late images, there's certainly dysfunction, which is what that little patch is. So we do an OCTA in all these chronic patients just to make sure there's no secondary neovascularization, which is what we see in 40% of cases. And then we zap it with the PDT laser. So that's a light exposure. It's completely painless. And we shine a red light, a 689 nanometer laser at the area of choroidal dysfunction. And then before treatment, you can see the choroidal thickness was here, subretinal fluid was there. And then after treatment, the choroidal thickness goes down, the subretinal fluid completely disappears, and then the effects, there's often some recovery in the anatomy, and that can take up to a year. So cone cells can take up to a year to recover. So we tend to look at patients 2 months after PDT just to see whether they've got a primary response, and about 9 to 10 months afterwards just to see they get an enhanced and no reactivation. And this is a very complex and chronic patient who had a PED and pachychoroid pigment epitheliopathy, who we treated. The other eye had a bad outcome, very widespread changes with pigment epitheliopathy, foveal atrophy, and then there's macular atrophy in this eye as well. So we are worried about this eye. And then these classic gravitational tracks where there's chronic persistence of fluid, eventually gravity migrates fluid downwards. Sometimes you can get inferior bullous detachment in patients as well. And then choroidal vessels, all very, very abnormal. Just whiz through these, all this bright leak is choroidal dysfunction, and then no neovascularization. So we map out the treatment zones. There's only a certain size and radius of laser treatment that we can do. So just to show, this is pre-PDT, and then after PDT, sort of quite amazing results. The serous PED disappears, the subretinal fluid disappears, the intraretinal cystic changes settle down, and the choroidal thickness goes down as well. But we can see that actually the photoreceptors have been irreversibly damaged. And then there's a big patch of atrophy here, which is why you can see all these transmission defects. But it does work, and it works amazingly well. And this was particularly important for this chap because obviously his foveola is just about preserved, so he'll maintain vision. Obviously, vision was quite poor in this eye because his fovea was completely atrophic. But we did PDT this eye, and that dried out too. So it'll stabilize the situation and stop things just going into a terminal decline. Because the longer it persists, the worse the vision. So I'm going to stop there. I'm just going to whiz through the rest of this talk because some of these things just don't apply. I'll just mention this whole business about CNV detection. So we think I've already mentioned that the OCTA is really essential and key. It's the only really reliable way of picking neovascularization. And there's this concept that these patients develop neovascularization as a reparative mechanism because it's ischemic. New vessels, it makes complete sense that new vessels invade in. They don't particularly leak, but they can tip the balance. So they are difficult to do, and the literature seems to suggest anything between 95% of cases and 25 to 40% of cases get neovascularization. That's certainly our experience at Thomas, as we think about 40%. And they're difficult to treat. And historically, we didn't really know what to do. But what we tend to do now is we'll do 3 anti-VEGF injections. And if there's a VEGF driven component, it will settle down. And then we'll do a supplementary PDT just to shrink the choroid. And of course, anti-VEGF is what's called an angiostatic agent. So it just stops the leak and stops the growth. Whereas PDT is angio-occlusive, so causes the neovascular complex to involute on itself. We'll just go to the summary slide, which is here. So what we've done is we've covered this whole emerging definition of the pachychoroid spectrum, and it is a broad number of diagnoses within that. CSR is just one aspect, but the things to particularly look out for is secondary neovascularization and chronicity. We always recommend you intervene when things are chronic. So again, there's a bit of a gray area, but somewhere between 4 and 6 months is optimal for intervention. Treatment about 6 to 9 months. PDT is the gold standard treatment. It works amazingly well, and it works better when people are treated and don't go into this chronic stage. And the ultimate aim is to preserve the outer retina, because actually without a retina, as you all know, you're not going to get good vision. And we see time and time again in clinic patients referred in for second opinions where patients have been, because older patients do get CNV2, but there's such an overlap with AMD and chronic CSR. They both got subretinal fluid. They can both get cystoid degeneration. They both get drusen. Some get age-related drusen. Some get pachydrusen. But the chronic CSR who are neovascularized tend to be a bit younger. The vision tends to be a little better. It tends to be a little bit asymmetric too. So I'll stop there.
Right. Thank you, Mr. Mohammed. There was a question in the chat. BG was asking whether we know why outcomes are worse in East and South Asians.
Well, that's where genetics comes into it. So it'll be, you know, we'll answer that once the genetic profile. So there's a few studies going on trying to unravel the genetic basis, because if only some people respond to steroids, if there's certain, because we hardly ever see black patients with CSR. I can't recall ever treating a black patient with chronic CSR with PDT. We treat black patients with PCV as part of hypertension, and you know, we rarely see AMD in black patients. So it's genetics which explains that, but we haven't got the exact genes and loci. But it'll be like AMD. There'll be multiple risk alleles on numerous genes. And there's overlaps because the complement factor H, which is key to inflammation, and this is disordered inflammation and steroid response, is also implicated. And there's the overlap there with AMD, the CFH gene, and the ARMS2 locus as well. And then 2 or 3 of the other loci which have been implicated are also risk loci for AMD. So, you know, these things are all starting to converge again on a genetic profiling.
Okay. I'm not sure if you can hear me. I have one other question. Mentioned some, you know, referring in based on chronicity, and then you also mentioned the fact that acute may be a different entity, and if we have recurrent acute, how do we differentiate in terms of referring in? So if we have a patient who has CSR, has an acute looking, but no changes, do we
Well,
then watch? What should we be doing in community?
well, if it's recurrent, so the ones you can sit on and not refer are the ones who settle within 3 or 4 months and don't get a recurrence, or are persisting beyond that period. So most patients will fit into that acute, meaning settle within 3 or 4 months and not recur. So anyone beyond that should ideally be referred in. Because if they've got this relapsing, remitting pattern, it's often just as harmful as true chronic disease, even though there is a difference.
Yeah, perfect. Thank you. Jaspreet's got a hand up. I mean, she may have a question.
Yeah, sorry, I have a question. I just thought it's easier to ask you than write it. You were saying just here at the end that when you treat some of the CSR with PDT, that
Yeah.
some of them develop the CNV. Over what period of time do they get that? And what percentage of patients who have had PDT would get that?
Yeah, no, it's
And
not the
how
PDT.
can we manage them in practice?
Yeah, it's not the PDT which causes the CNV. It's the CSR, the chronic CSR, which
Oh, I see.
causes the
Sorry.
CN. Yeah, so sorry, I probably didn't make that clear enough. Yeah, it's chronic CSR, which then drives people to getting near. PDT is a treatment which works brilliantly for chronic CSR, and it also works pretty well for CNV. So PDT was originally developed to treat CNV. So we kill two birds with one stone. So we address the neovascularization, but we also address the choroidal dysfunction and choroidal thickening with PDT, which is why it works well. But
Sorry, so because you were rushing through it, I kind of misunderstood what you say.
right, so the late complications of chronic persisting CSR are foveal atrophy, outer retinal disease, chronic pigment epitheliopathy. So that damages the retina. But in response to that chronic disease, the body is trying to repair that, it's the same theory in AMD, where those new vessels grow in response to VEGF. VEGF is secreted because of ischemia, wherever that ischemia may be. And same with diabetes, it's still VEGF driven, it's still neovascularized, it just happens in a different plane. All the diseases, all the everything we treat with anti-VEGF agents is driven by VEGF, which is the key cytokines, key chemical signal which promotes new blood vessel growth. And it's no different in CSR. So it's chronic CSR. So over all the patients of CSR that we see, 85% will settle, 15% to chronic. And out of that 15%, about half will end up getting neovascularization if they're sat on. Neovascularization tends to happen when disease has persisted at least a couple of years or so, which is why it's better to treat early because they preserve their photoreceptors, the RPE remains relatively intact, and more importantly, we avoid neovascularization, which then doesn't go down the expensive and time-consuming and risky anti-VEGF process.
Okay. All right. Thank you.
Brilliant. Thank you. Mr. Mohammed, I mentioned to you earlier that an optometrist in South East London did come to us with a case that they wanted to present. I wonder,
Sure.
Annie, are you there?
Hi, Davina. Yeah, I'm here.
Lovely. Are you able to share your screen, Annie?
I'm
Or
actually not. I'm on my phone,
oh, are you?
so I might not
Okay,
be able
fine.
to. Sorry.
No, that's all right. I will try and share from mine, except um my service is rubbish. And Annie, if I present, are you okay to discuss? Is that all right?
Yeah, I'm happy enough to. Yeah.
Amazing. Um, Let me see if you can see it. Can you see the screen?
Yeah.
Yes, I can.
Okay, amazing. So I'll just go to the next one. Annie, if you could just introduce the patient and the case.
And yeah, so this is 56-year-old male, and he presented to me just for routine eye test. So first time we had seen him in practice, coming in, good general health, no medication. He mentioned very blasé that he's under the care of King's at the moment, and he is seen every few months for a retinal issue. Thankfully, he was able to come back to me with his hospital letters and realised that he had a diagnosis of chronic CSR, but he hadn't had any treatment yet. And on the letter as well, it said that he had bilateral pachychoroid, and he was also, interestingly enough, a primary angle closure suspect, and he had bilateral LPIs a few years ago. So that was all good, and his vision was fantastic, 6/4.8 right and left, and he had no symptoms on AMSR either. So I think we had some good images from, yep, so these were the Optimap images we had in June. So that was right eye, and then that was the eye that had the CSR, and then the left eye, I think it's the next one. Yeah, there was definitely less CSR in the right eye. So everything was all good in June. So he's still under the care of the hospital, but then came back to me in July time. And he came back to me mostly because he said he wasn't getting on so well with his glasses and his vision in his right eye had dropped. So, sorry, I meant to say as well, back in June, I told him to go see his GP because I was like, he might have some high blood pressure. And now he's under the care of his GP because his blood pressure was quite high. So we redone the images again in July there. And these were the OCT images that we got. That was the first one. And then there was another OCT, I believe. That was the second one. And then there was two more just of the Optimaps that we got, which otherwise seem quite similar to the images we took in June. So that was the right eye and then left eye. And so after I seen him in July, I've just referred him urgently back to the care of Kings. But I would describe the photos, but when Mr. Mohammed's here, I'd rather not go into too much detail.
No, it's no, they're great. It's a great case. So if you go back right to the first slide, and I'll just comment on all your slides. So we said CSR, yeah, second slide. So is typically a disease of hyperopic, presbyopic men. So 56-year-old will fit into that. It tends to be in people who are hyperopic. We're guessing he had laser PIs, slightly shorter eye than usual. So that all fits as well. And the vision was great. So of course, we primarily treat people with central macular or foveal involvement. If they're asymptomatic and the vision's good, then you have to ask the question, what are you treating and what are you preventing? So if you go to the next slide, so this picture shows a very characteristic appearance of CSR. On the color picture, you can see RPE changes, but the autofluorescence tells us everything we need to know. Just above the disc in the superior nasal macula, there's RPE changes, which light up bright and dark. But then inferiorly, you've got that big patch, but it's just skirting the edge of the fovea, which is why his vision's remained good. And I guess that's possibly why he didn't have any treatment at King's. It depends on what the foveal OCT looked like at the time. If you look at the next slide, and we've mentioned as part of the talk that you often get bilateral asymmetric disease. Things like AMD tend to be very symmetric, but almost the rule for CSR is asymmetry between the two eyes, and you can see lots of RPE changes. They're all mainly inferior. I mean, he's unusual in the fact that his changes are just slightly off center. Was this patient Caucasian?
Yes, he was.
Yeah. Okay. And then go to the next slide then. So it's your yeah. So he obviously then became symptomatic. The vision went down. He had distortion. That's a classic symptom. And June and July, so he progressed. So actually, there's little PEDs just adjacent to the fovea. Most of his changes are, and then he developed subretinal fluid involving the foveal center, which is when the vision went downhill. So we don't like big PEDs close in. So I would end up being more inclined to treat this patient, most likely with PDT, because big PEDs tend not on angiography to have single leakage points. It tends to be little tiny PEDs which do that. So when you have a much more sort of wider little pigment epithelial detachment, that's that little bilobed hump thing, just nasal to the fovea. And then he's got a wider pigment epithelial detachment because you can see Brooks membrane there. And of course, things can fluctuate. Most patients do wax and wane a little bit, but when he's got such widespread RP changes, it's easy enough doing PDT. Anyway, we'll see what Kings do then. But it's a nice case. So, and this is the nature of CSR, that it often in some patients does wax and wane. So again, in June, where was that cut?
And that was
Yeah.
temporarily.
Oh yeah. Okay. Yeah. So that's going in through some RP irregularity. And he's got some fluid out there now as well. You can see off that surface map where his fluid is. So he's got a big
Mhm.
puddle of fluid. So, you know, it is true chronic disease by definition. It's well, this episode affecting the fovea, it's a moot point as to whether you say he's got chronic symptomatic or not. We tend to have a lower threshold for treating patients. So, yeah, it's always up for debate, isn't it? But we think patients often do badly in the long term. So that fluid, if it persists and doesn't settle spontaneously, will nibble away at his retinal function. And his phenotype in this individual, he's got quite a big area of pigment epithelial irregularity. That is not going to do well in the long term. He's still young, 56. So the best way of preserving that retina in the long term is with PDT, and PDT will minimize future fluctuation or recurrence.
Okay. Thank you. I just wanted to quickly just add in for any of the attendees that haven't put their GOC number on, can you please put your GOC number on after your name so I do count your GOC points? Mr. Mohammed, there was 2 more questions and then we'll call it a night if that's okay. One of the attendees has asked, you mentioned focal choroidal excavation. Can you talk a little bit more about this?
I can. It's what it says on the tin. So there's a question at the moment as to whether this falls on the pachychoroid spectrum. So one of the things we said is it's the choroid which is abnormal, and it probably is, rather than choroidal ischemia, a choroidal infarct. So then the choroid, rather than just being thin and poorly vascularized, has probably just completely collapsed in. So something has obviously caused some sort of lobular infarct, and then that thickened choroid then just gets this excavation. And there's these 2 broad types where you have either conforming, where the retina seems to just line the defect, or non-conforming, where it just zips across and you have a cavity. That's really all there is to say on it. You know, as we said, as part of the CSR and pachychoroid spectrum, we've got all these different changes: CSR, pachychoroid neovasculopathy, pachychoroid pigment epitheliopathy, and focal choroidal excavation is part of this evolving landscape of changes we see in patients with pachychoroid diseases. So when we look at all our chronic CSR patients who we've treated with PDT, a minority, but very definitely seen in that group of patients that we see them. But as I said, there's a debate at the moment as to whether it is of any relevance at all.
So if we in community
See
see
that?
yes,
Yeah, it probably should be referred in because
okay.
we want to see, is there any other cause? Because other inflammatory choroidopathies will cause that appearance too.
Okay. Amazing.
And they're the
And
things not to miss.
the last question, and then I'm going to definitely close the evening, is if a patient has an odd, small serous PED that is peripheral to the fovea, are they more likely to get CSCR?
Well, there's lots of reasons why people get PEDs. So if it's part of the right age spectrum and it's in part of the pachychoroid spectrum, meaning they have got a thickened choroid with anomalous outer choroidal vessels, it's not necessarily they're more likely to get CSR. You just got to make a decision. Is that PED problematic or not? So out of the CSR patients we see, the textbooks say there's often this smokestack leak and ink blot leak, which you may recall on angiography. Almost always the smokestack comes from serous PEDs. So a pigment epithelium is a single layer of cells. When it's been detached, if it breaks and breaches, because any cell they're attached side by side as they sit next to each other. If they're pulled apart, it's only a single layer of cells. That micro rip is enough to then pour fluid into the subretinal space. So yeah, theoretically, they're at greater risk of developing a serous retinal detachment as part of the CSR complex. But articulated PEDs we see in patients with part of this pigment epithelial changes that you see as part of the spectrum. So patients with CSR in one eye, look in the other eye, you'll always see RPE changes, and those RPE changes may be white spots, pachydraes, and dark spots, mottled irregularity, or isolated PEDs. So any of those things. So it's part of the spectrum. It's one of the things we see. If it's away from the foveal center and they're asymptomatic, I'd just sit and watch it. But yeah, you warn them that they're slightly at greater risk of developing acute CSR.
Okay. Thank you so much. I'm going to stop recording.